talk on surgical adjuncts for maximal safe resection of brain tumors. I am Dr. Vishnu Reddy, Chief of Anesthesia and Medical Services at Yeshoda Hospitals, and I am your moderator for today. So a very brief introduction to Dr. Anand Balasubramaniam. Dr. Anand has done his medicine and emergency surgery from Tumor, and then his MCH neurosurgery and DME neurosurgery from NIMHANS, and his next associate professor of NIMHANS. He did his fellowship in neuro-oncology at University Hospital Network, Toronto, that's Hospital for Sick Kids, and Toronto Western, which is one of the most accomplished hospital and one of the most, this hospital has maximum number of cases, so he has done his fellowship from this hospital. His specialty interest is minimally invasive neurosurgery, stereotactic endoscopic procedures, and radiosurgery. Image-guided surgeries like gliomas, pituitary adenomas, and for Parkinson's disease, deep brain surgeries are something which Dr. Anand does on a regular basis. And he is the proctor for DBS surgeries in India, and he keeps going across India to proctor on this DBS surgeries. Apart from this, I think Dr. Anand Balasubramaniam has a lot of experience in intraoperative MRI-based neurosurgeries, where he is working presently in Yeshoda Hospital, Secunderabad. It has a 3 Tesla intraoperative MRI neurocenter, and we have been doing many cases in this field. And I think it has been recognized across India, and they have done mostly maximum number of intraop MRI surgeries. I think with this brief introduction to Dr. Anand Balasubramaniam, I hand over the proceedings to Dr. Anand to continue with his talk. Thank you, sir.
Thank you very much, Dr. Vishnu. Thanks to Anbai for giving me this opportunity to discuss on the topic on which we are working on. It's an interesting topic for students. I'll straight away go to sharing the screen. And so the topic I have chosen to speak on is surgical adjuncts for maximal safe resection of brain tumors. Now, in neurosurgery, the brain tumors has been one of the last frontiers, kind of, because of various limitations. Unlike tumors elsewhere in the body, which are easy to resect as a whole, brain tumors do not provide the ability to be resected as a whole. We have to follow an inside-out approach, make a small hole in, and then dig ourselves through from inside out. It's like peeling an apple from inside out, decoring the apple from inside out, because it's embedded in functioning neural tissue, and excising with a margin of neural tissue is not practically feasible. It will be at the cost of functionality of the brain. And in extraaxial lesion, even though total excision is feasible, safety has always been a major question because of the surrounding nervous tissue from which the tumor has to be peeled off. So it has always been first a difficulty to localize these tumors. Then with a lot of imaging, we were able to localize where the problem was. Then reaching the area was a problem which a lot of us have dared to operate even without microscope. But now we have plenty of technology which has made the surgery for brain tumors safe and a worthwhile proposition. For intraaxial lesions, the problem is even more diverse. From intraaxial, I mean parenchymal tumors within the brain. So here, the margins are pretty diffuse. They are usually merging with the margins. They are infiltrative, intermingled with normal brain. So total excision is only theoretical, in the sense we are only able to remove macroscopic disease as seen maybe on an MRI scan. There is going to be a lot of microscopic disease in the periphery, but and that is going to compromise the function there. Still, it has been proven very well that gross total resection of whatever you are able to see macroscopically on an MRI makes a long argument for overall survival and progression-free survival to be increased. So that's why the term maximal safe resection has come into stay. And for all intraaxial brain tumors, one should always try to go for a maximal resection. However, it should be safe. So what has happened so far in the last, maybe till the last decade, we used to resect what was at, within the limitation we have, do a neural decompression, and the question of safety is all that. So more subtotal resection. As a like for example, microscope, MRI, where we can see with good fiber tracking exactly where the fibers are with respect to the tumor, ultrasound and intraoperative MRI imaging. We are navigated and the safety component is visibility with a micro. The most important adjunct that we have, mobile arm, which can easily be unlocked with a magnetic switch, and you can have good